afternoon, everybody. I'm here to introduce Majid Kajbafzadeh, and I did need quite a lot of training in how to say that. Quick intro to Majid. He did his undergrad at SFU and graduated with a BSc in Health Sciences. During that time, he was part of a neurobiology research team investigating the role of dopamine system in the pathophysiology of different diseases. He's currently in the final stages of wrapping up his MSc thesis in occupational and environmental hygiene at UBC. Welcome, Majid.
Thanks for the intro. After 2 years of sitting there watching all those brilliant presentations, it feels great to be up here and have something hopefully worthy of your time. So I'm going to present my master's work today, which was focused on using HEPA filtration as an intervention to look at the cardiovascular effects of exposure to traffic and Woodsmoke PM. I'll start with some background. Every year, about 3.2 million people die prematurely of causes attributed to exposure to TRAP PM. In Canada, this figure stands at around 21,000, which is over 9 times the number of traffic accident deaths in Canada, resulting in about $8 billion of economic cost in 2008. There are some estimations that this will continue to increase and will add up to $250 billion by 2030. Here's a figure presenting the sources of air pollution in our region, in the Greater Vancouver region. As you might have noticed, most of the exposure is coming from sources of combustion. I could say over 50 to 60%. Two of the major sources of combustion that we looked at in our study included traffic-related air pollution, which is mostly present in urban areas and close to major roads, and wood smoke exposure, residential wood combustion, which is present mostly in mid and high latitude regions in northern North America and northern Europe. In Metro Vancouver, about 24% of the emissions, traffic-related emissions, are from PM. And considering the fact that approximately 90% of the PM coming out of tailpipes is PM 2.5, in the PM 2.5 range, which I will get to as to the significance of this size, and also the fact that 30 to 45% of urban population in North America lives in close proximity of major roads and highways, you could only imagine the extent of the magnitude of the public health effect that such an exposure can have. Looking at residential wood combustion, it accounts for over 25% of PM 2.5 exposure. In Canada, it's about 11% in Metro Vancouver, and just a fun fact that I included, in GVR, 34% of homes have wood burning devices, which is mostly for aesthetic use. Wood smoke is becoming more significant with regards to its public health effects, with the increasing cost of other fuel sources. And also the fact that it's relatively unregulated compared to other combustion sources of pollution. Excuse me. Considering that we use wood mostly in cold months, in winter months, and that air stagnation is worse during those months, we could have layers of PM 2.5 from wood smoke, which would stand still over cities and lead to prolonged exposure and potentially adverse health effects. Here are some of the health effects related to TRAP PM. I included lung cancer on top of the list, mostly due to the fact that a couple of months ago, IARC changed the classification on PM 2.5 and traffic-related air pollution to group 1 carcinogens, carcinogenic to humans, among others, including decreased lung function, asthma exacerbation, increased ED visits, emergency department visits, cardiovascular disease, and there's also some suggestions as for reproductive effects, birth defects. With regards to residential wood combustion health effects, there's some evidence that the respiratory effects are not that different compared to TRAP. However, there's very minimal evidence and very few studies that have looked at the cardiovascular effects of wood smoke, so there's no conclusive thoughts on that. I've talked about particulate matter for a bit now. You might be asking what It actually is. So these are tiny particles consisting of liquid and solid components. The sources can be both man-made, such as combustion of different types of fuel, or natural, such as with volcanoes. They are generally categorized into three categories: PM10, PM2.5, and ultrafine PM.1. I've included this figure on the slide, which many of you have seen probably a million times. This is a hair strand with which has an average diameter of 50 to 70 micron. If you want to have PM2.5 particles in the diameter of this hair strand, you could fit at least 20 to 30 of these particles. So you can only imagine how small these are and how deep they could penetrate into the respiratory system. So where does it grow in the body? Among the other factors such as charge, composition, size is one of the more important factors in knowing where these particles end up. Generally, for the larger particles, there is a better clearance system in the body, and the body's natural defense removes them better. But with particles smaller than PM2.5 and ultrafine, they tend to stay longer in the body and also penetrate deeper, which could be a cause of concern. This figure represents two of the many different hypothesized pathways of that PM can affect cardiovascular health. Here on, we'll use the mouse pointer. Here on the left, you can see the classical pathway, which is basically when you get exposed to PM and you breathe it in, the inflammatory system becomes activated and the macrophages start engulfing these particles, leading to a cascade of other events such as production of more inflammatory proteins and other molecules. So after that, with the interaction of the PM with the macrophages and the alveolar epithelium, this can become a systematic issue, so we could have systematic inflammation in the body. Here on the right-hand side, what this is basically showing is that they hypothesize that PM, after it enters the lung, it can somehow pass the alveolar epithelium directly into the bloodstream and then interact with the vascular endothelium and potential atherosclerotic plaques in the body, leading to localized and systematic inflammation and cardiovascular disease. The third pathway that I haven't included in this slide is that after exposure to PM, certain receptors in the surface of the lung get affected by those, and then the fight or flight system of the body gets triggered with increases in inflammation. In my work, I've focused on cardiovascular effects of PM2.5. In this slide, it provides a summary of epidemiological evidence related to traffic-related PM2.5 cardiovascular events. On the top portion of this table, you can see the clinical cardiovascular endpoints related to exposure to PM. And this, I should note that these arrows do not indicate the magnitude of the effect. They're basically the number of studies and the quality of the studies that have found an association between PM and cardiovascular health. So you can see there is some evidence on cardiovascular mortality, hospitalization, and heart failure. Looking at subclinical cardiovascular endpoints, again, there is some evidence on systemic inflammation, endothelial cell activation, blood coagulation, and endothelial dysfunction. For the purposes of my study, we focused on only subclinical cardiovascular endpoints such as systematic inflammation and endothelial dysfunction. There has been evidence that inflammation does affect heart disease, systematic inflammation, I mean, and one of the most prevalently used markers of systematic inflammation is C-reactive protein. In this systematic review of the literature, you can see 10 different studies that have looked at C-reactive protein and heart disease, and they've all found relative risks greater than 2, between 2 and 5 for different types of cardiovascular health events. Our other endpoint that we looked at, endothelial dysfunction, It's basically the imbalance between vasodilation and vasoconstriction. And one of the main vasodilators in our body is nitric oxide, which helps with this process. Besides its vasodilative properties, it also helps with reducing systematic inflammation and also platelet adhesion and coagulation, which plays a major role in atherosclerosis in the body. So you could imagine that the reduced bioavailability of NO could be involved in the initiation, progression, and complications of atherosclerosis. This marker has been used for as a predictor of future cardiovascular events. Different studies use different methods to look at the effects of exposure to PM and different health outcomes. These could include exposing participants in a controlled environment to certain air pollutants such as diesel exhaust or gasoline exhaust, wood smoke, or having people in different settings in the real world, such as having them bike in areas of higher air pollution and lower air pollution, and then looking at what the difference was in the health outcome of interest. One of the more innovative methods has been using HEPA filtration to produce a concentration gradient in homes, and then looking at the before and after picture of the health outcome. So what is HEPA filter? HEPA stands for high efficiency particulate air filter. This picture shows only the filters themselves. They're used in medical facilities, laboratories, factories, and homes. They're believed to remove 99.97% of particles that have a size of 0.3 microns. Here are a couple of pictures of different models. This model on top left is, I think, the nicest looking one of the nicest looking ones, which I don't know, whenever I see this I want to buy one myself just because it looks. But the more mainstream ones are this one and this one on the bottom. This is one of the filters that we actually used in our study. So looking at the literature that have used HEPA filtration to look at cardiovascular health effects of PM, in Denmark, Brown et al. Used HEPA filtration to look at the impact of TRAP, which stands for traffic-related air pollution, in their particles and endothelial function, systematic inflammation. They enrolled 21 non-smoking couples in this study between the ages of 60 and 75, and they had 2 48-hour periods, one with HEPA filtration in place, one with placebo filtration. What they found was significant improvements in RHI, which is a measure of microvascular endothelial microvascular function, with HEPA filtration. However, they didn't find any kind of correlation with CRP or other markers of inflammation. In this study, which was done by the same group in Denmark, they enrolled 48 participants between the ages of 51 to 81. However, the difference with the previous one was that in this study, about half of the population that they have did take medications, vasoactive medications, statins, and cyclooxygenase inhibitors. So, considering this fact, they did the same thing. They used HEPA filtration, but this time for a week, no HEPA for a second week. And then they looked at the effect on, again, endothelial function and systematic inflammation. What you can see here with regards to HEPA filtration, they did not find any significant association between filtration and any kind of improvement in endothelial function. However, using PM2.5 as their continuous exposure variable, they found that per 10 microgram per meter cube decrease in PM2.5, there was an 8.5% increase or improvement in endothelial function in the population that was not taking any kind of medication. And lastly, in this study that was done by Dr. Ryan Allen from SFU, who is my co-supervisor, they looked at the effect of wood smoke in Smithers as a wood smoke impacted community on endothelial function and inflammation. They used HEPA filtration again in this study as an intervention. As you can see in this first column, they found a significant improvement in endothelial function, about 8 or 9% improvement endothelial function with HEPA filtration. Looking at CRP as a marker for inflammation, they found a significant drop in CRP levels with filtration as well. They saw some drops with IL-6 and band cells, which are also markers of inflammation, which were not significant. So the purpose of our study was to evaluate the impact of HEPA filtration on indoor PM2.5 levels for both trap and Woodsmoke homes, and also to quantify and compare exposure-response relationships for trap and Woodsmoke with HEPA filtration and pollution concentrations. Here are the three hypotheses that we have. We hypothesize that portable HEPA filtration devices will actually reduce concentrations of PM2.5 in both home types. You might ask, do we already know this? The answer is not that simple. We do and we don't. Most of the studies that have looked at HEPA filtration and PM2.5 are in Europe, and the ratio of diesel gasoline is different in Europe. It's mostly diesel exhaust. So there haven't been that many studies looking at the effect of HEPA filtration on that in North America. Second, we hypothesize that reducing combustion PM2.5 levels by indoor HEPA filtration will improve microvascular endothelial function and reduce systematic inflammation in the body. And last but not least, HEPA filtration will have a greater impact on these endpoints among those exposed to trap PM compared to Woodsmoke. This is based on the available literature that trap, because of its components, can have a greater effect on the body, in addition to the fact that trap particles have been shown to get deposited in the lungs 16 times greater than Woodsmoke particles. I'd like to talk about the study design that we had. Our study design was novel with regards to different things, such as we looked at impact of trap and Woodsmoke PM2.5 in the same study. This is significant because we were using almost the same population, which I will get to in the next slides, the same population characteristics in the same city, but different exposures, which was unique in our study area. And this, to our knowledge, this is the first time that this has been done anywhere. We also used HEPA filtration for reducing exposure. So we looked at how the HEPA filtration would affect this, the endpoints, in addition to looking at how reductions in PM2.5 would affect this. So we used HEPA filtration devices to introduce a concentration gradient in our homes. The WHO workshop in 2007, the workshop ended with some recommendations to fill the knowledge gap present with regards to the effects of PM2.5 on different health outcomes, such as evaluating the effects of PM from sources other than trap, contribution of different sources of exposure to population exposure, using specific health markers rather than general mortality and lung function, and effects of air pollution reduction methods on health outcomes. In our study, we tried to address all of these recommendations, which have been included, and you will see for yourself how these were included. In addition to this, the other aspect that makes our study novel is the semi-experimental design that we have. Many of the studies that have looked at Woodsmoke and some that have looked at trap have been in controlled environments, exposing participants only to trap or Woodsmoke. However, in our study, we have the participants living in their homes, going about their regular lives, so being exposed to the ambient mixture of pollutants, not only one specific pollutant, and real levels of those PM2.5. So here's the general design of our study. We had a single-blind randomized crossover design, single-blind in the sense that none of the participants were aware of whether or not HEPA filtration was in place in their homes, and randomized in the sense that after enrolling participants in our study, we randomly assigned them to either of these two groups, One where HEPA filtration was in effect during the first week, no HEPA second week, and the other vice versa, no HEPA first week, HEPA second week. The sampling was conducted over 2 consecutive 1-week periods. HEPA filtration during the first week, placebo filtration, which is basically we took out the actual filters from the machines and then let it run for that 1-week period. The sampling, the exposure sampling equipment was placed in the main living room and outdoors, usually in the backyards to have them safe and sound. HEPA filters were placed in main living rooms and in the main bedroom. I should also mention that with regards to health endpoints, we measured endothelial function at the end of first week and at the end of second week. We also collected blood samples at baseline, end of first week, end of second week. For the purpose of our study, we needed to identify areas in Greater Vancouver region that were primarily exposed to either trap or wood smoke. What we did, we used previously developed spatial models for trap and wood smoke in this region. What you see in panel A is the map of Greater Vancouver region, and then the darker parts are parts with higher trap. In panel B, you can see the wood smoke tertiles. Again, darker areas have higher wood smoke exposure. And then from these two models, we extracted postal codes, which were either high trap, low wood smoke postal codes, or low trap, high wood smoke postal codes, to just to try to eliminate any overlap of exposure. Here we have the exclusion criteria that we used. We basically excluded any individuals with any kind of risk factors or prior conditions that would affect their cardiovascular health or endothelial function, including recent surgery, diabetes, heart disease, hypertension, and so on. We also excluded downtown Vancouver and those living above a 3rd floor. The models that we used were mostly based on nitrogen oxide and nitrogen dioxide. So based on the available literature, there's a vertical concentration gradient that we thought the models would not be accurate in characterizing exposure in these regions. We managed to recruit 83 healthy adults between the ages of 19 and 72 in 44 homes. The 29 participants were from homes in areas of low trap, high wood smoke, and 54 from areas of high trap, low wood smoke. Here's a table summarizing the health and exposure measures that we had. Reactive hyperemia index, or RHI, which is a measure of endothelial function, a C-reactive protein, which was our primary systematic inflammation endpoint, and interleukin-6 and band cell counts as our other systematic inflammation endpoints. We had PM2.5 as our primary exposure measure, along with Hopkins as our traffic marker, levoglukosand, wood smoke marker, and so on, as you can see in the table. In order to measure endothelial function, we used a device called EndoPAT, which basically includes 2 probes that you attach to both fingertips of both hands, and then you have a test hand, a control hand. What you do is the patient or the subject has to lay down in a quiet and preferably dark room, and you can start running the test by having a blood pressure cuff on the test hand only. You start the software that comes with the device. You go for a baseline measurement, which is this pre-occlusion segment for 5 minutes. And then after 5 minutes, you have to inflate the cuff to cut off blood supply to the arm, which is this flat segment in the middle. This goes on for 5 minutes. And then after 5 minutes, you have to quickly open the cuff to let blood back into the arm. And what you look for is defined increases in these signals. This is a normal response that you would expect, a very fast, quick increase in the signal strength. And this is an abnormal response where you have a, if I may call it, a cone-shaped increase in signal strength. And then this will give you a score, which is called the reactive hyperemia index. And from that score, you could interpret the score as whether or not someone is predisposed to some cardiovascular health event, future. I used JUMP 10 from SAS Institute to analyze the data. The outcomes that were skewed were log transformed, and I should mention that only subjects with data, both health and exposure data, for both weeks were included to protect the integrity of our crossover study design. We also used pair t-tests for easier interpretation of differences in means. We used also mixed effects models to account for measurements clustered with individuals and individuals clustered within home, in addition to some sensitivity analysis. So before I go into the core results, I would like to set the context of how these results would be looked at. So we use HEPA filtration in the homes. We suspect potential inconsistency with HEPA filtration use. Even though we used electricity meters attached to the HEPA filtration devices to ensure that they were actually on for the period that they were supposed to be on, we still can't say how long they were on what setting, high, low, or medium. The England's PM2.5 concentration, as you will see, were very low. We're living in one of the cleanest cities of its size in the world. So this low ambient concentration led to very small concentration gradient introduced into homes. So considering these facts, I'll move on to the results. Here's a table summarizing the study population characteristics. What I would like to bring your attention to is the fact that looking at age, BMI, the blood pressure measurements, you can see that we're dealing with a relatively young and healthy population, and considering the fact that we excluded anyone with any predispositions for cardiovascular health issues, this is a relatively healthy population that we looked at. Here I have some of the exposure characteristics. You might have noticed the difference in outdoor temperature between trap and Woodsmoke homes, which we expected. Woodsmoke homes were sampled during the winter months, as that's when Woodsmoke wood use is most prevalent. Most of the other variables, such as indoor temperature, PM2.5 outdoors, indoors, they're pretty close to each other. Despite the statistically significant difference, they're relatively close to one another. So here's some more exposure characteristics. Indoor absorbance as a measure of black carbon, and trap. There was a slightly higher concentration or absorbance in trap homes compared to Woodsmoke homes. And with HO panes, which were markers of traffic related air pollution, you can see higher HO panes in trap homes than Woodsmoke homes, both indoors and outdoors. Yes, I stratified some of the exposure variables based on based on home type and filtration status. Again, what I would like to have your attention on is the drop in PM2.5 levels in both trap and Woodsmoke homes. Overall, we're looking at a 40% drop in all homes in PM2.5 concentrations. We had a higher drop in Woodsmoke homes, about 48%, and 38% in trap homes. With regards to the categorization of the home, we used some of the data that we had to verify that we had actually correctly identified and categorized homes into trap and Woodsmoke areas. Looking at levo-glucosan, which is a marker of Woodsmoke, we can see that the outdoor levo-glucosan levels, the Woodsmoke homes have 3 times the concentration than compared to trap homes. And then with regards to the categorization of trap homes into the respective areas, we looked at distance to nearest highway and a major road as a source of trap. And what you can see here is that Woodsmoke homes are almost over 7 times further away from these major roads or highways. And then looking at highway or major road length in a 100-meter buffer of these homes, again, you can see that it's Woodsmoke trap homes have 10 times a greater length of road close to them. So we're quite confident on the categorization of the homes that we did using the models provided. Moving to the results, I should probably say disregard the label here. I said exposure increase, but this is, I was thinking statistical codes for HEPA filtration, which is 0, 1. So it's basically exposure decrease for HEPA filtration and exposure increase for PM 2.5 exposure. And here I've included results from the models for all homes, which is represented by circle, square for trap homes only, and then Woodsmoke homes only using a triangle. What you can see here is we were expecting an improvement in endothelial function, which is represented by increases in RHI for RHI. So here we see the opposite. We see effect estimates opposite to what we actually expected. Looking at PM 2.5, again we expected drops in endothelial function, worsening of endothelial function with increases in PM 2.5 exposure. However, here we're seeing improvements in endothelial function with increases PM 2.5 exposure. Although I think I should mention that these effect estimates are very small with very wide confidence intervals. With regards to CRP, we expected a drop in CRP levels as a marker of inflammation with filtration. However, we're seeing very small positive increases in CRP levels with filtration. However, looking at PM 2.5, for all homes, there's a non-significant increase in CRP levels per unit median increase in PM 2.5 concentrations. After stratifying the models by home type, in trap homes only, we had a borderline statistically significant increase in CRP levels per unit median increase in PM 2.5. And the value of the effect estimate was we were looking at about 20% increase in CRP levels. And the p-value, I think, was 0.055, so pretty close to being statistically significant. However, we did not see such an effect in Woodsmoke homes. It's actually in the opposite direction. IL-6, our secondary endpoint of inflammation, the same thing. With HEPA filtration, we saw the opposite of the hypothesized direction that we expected. For all homes and trap homes. For Woodsmoke homes, there's a small reduction in inflammation with filtration, which is very small and very wide confidence intervals. For PM 2.5, again, they're opposite to what we expected. Band cell counts. Here, again, we did not find anything significant with band cell counts in our study. For neither HEPA filtration nor PM 2.5 concentrations, and for PM 2.5, all effect estimates were negative, meaning reductions in band cell counts with increases in PM 2.5. In addition to band cell counts, we looked at percent polymorphonuclear something. Okay, anyway, so we looked at the PMN. These band cells are immature PMNs. So what we were trying to do was look at whether or not PMN band cell counts are actually increasing with compared to the available PMN in the body. So again, we found nothing significant. It was consistent with the band cell count measures that we got. I should also mention for all of these models, we also looked at absorbance and level glucosan, and we did not see any kind of association, significant association between any of these outcome variables and absorbance and level glucosan. We explored effect modification by age, BMI, and sex. With regards to age and BMI, we found no significant effect on any of the mixed models. However, using sex as an effect modifier, we found that PM2.5, the PM2.5 effect that we found, the 20% increase in CRP with increases in PM2.5 was only present in males. In fact, for females, it was in the opposite direction, meaning a protective effect. So as per hypothesis, HEPA filtration was associated with a 40% decrease in indoor PM2.5 concentrations, more so for Woodsmoke homes than traffic homes. However, we had inconclusive evidence on relationship between HEPA, PM2.5, and endothelial function. Indoor PM2.5 concentrations were associated with blood CRP only among traffic impacted homes, and this was consistent with our a priori hypothesis that trap particles will have a greater impact on cardiovascular health compared to wood smoke. We found no evidence of association between HEPA filtration or wood smoke PM2.5 concentrations and any of the inflammatory markers. Likewise with IL-6 and band cell counts. In general, I could say there was a lack of conclusive evidence on potential differences in cardiovascular effects between the two home types that we looked at, although CRP results may suggest stronger inflammatory effects for traffic-related particles. What I should probably mention is, again, remind you all, this is a very small concentration gradient that we're looking at. We had a drop of, I think the average drop in homes was nearly 2.5 micrograms per meter cube. And with a healthy population with absolutely no risk factors that at least we knew of, this increase in CRP levels might be suggestive of other effects on cardiovascular health. I'll go into limitations for a bit. We were aiming to recruit about 100 participants, 50 living in wood smoke impacted homes and 50 in traffic. However, we failed to do so, and we only managed to recruit for 83. However, I should also mention that when looking at RHI and CRP, again, we had to exclude more people because of lack of data, either for those health outcomes or because of issues with our exposure measurement instruments. As a result of this, we had lower statistical power than what we had actually aimed for and expected. So we might have missed small changes in cardiovascular effect in our endpoints due to this. As I mentioned before, HEPA filtration use consistency could have been an issue in this study. Very low PM2.5 levels generally, which is, I guess it's a good thing, but for our study it didn't really help us. Looking at endothelial dysfunction, we used EndoPAT as our device as a device that helped us do this. The literature is kind of split on using this device and its consistency with other clinical methods that have been proven to work. However, it's the least invasive and the easiest to carry out on the field. There are many studies that say it works, and it is measuring what it's supposed to measure, and there are some studies that say otherwise. Finally, I would like to thank Mike Bauer and Ryan Allen, my supervisors, Chris Carlson, Dr. Stefan Van Eden, and Barb Carlin. Our study technicians, Paul Adam and Mauricio Zapala, and our funding sources, the Canadian Institute for Health Research and Create App from UBC. Thank you.
Thank you, Majid. We got time for lots of questions. Anybody have any questions?
Thanks, Majid. It's a very interesting study and great presentation. Got a question about if you were to look at a population or study population of those with underlying diseases such as asthma or those with some respiratory diseases like emphysema, chronic obstructive pulmonary diseases, what might you expect to see different?
With regards to cardiovascular health?
Yes, with respect to, because there's an association between asthma and cardiovascular disease, so I'm just curious about your interventions. What might you surmise as a difference coming out?
I think what we were aiming for was exactly what you just mentioned, that many of these conditions do affect cardiovascular health. And so I would think, based on the available literature, that we would have seen an effect on cardiovascular health. It's tricky because the concentration gradient was so small, and we still don't know, as with many other exposure, we still don't know if, we know there's no threshold, but we don't know down to how low we can go before we can see a measurable difference in the health effect that we're looking at. So it's really tough to comment on with this, with the concentrations that we had and the gradient that we had. But I think with higher concentrations, we might have been able to see effects.
Thanks, Majid. And always a good example of when to have an example of a study that sometimes you don't have the really big p-values, but that doesn't negate the study in any way. But along that line, okay, is that all of these kinds of studies do feed back into how we interpret policy or how we interpret the need to change levels, you know, through legislation and things like that. If you were invited to a town hall meeting and were asked to support and or not support a initiative to reduce the amount of pollution in, was that the Belcara area or the areas where they're using wood smoke? Yeah. How would you explain the results to either legislative people or to members of the public?
I think at this point, what's lacking is more studies in this field. It's right now, it's only in North America. I think the first study was Ryan Allen's Smithers study. It was in Smithers, the Woodsmoke, and now we have this one. So I would guess it would be a tough task convincing them, especially with these results. With the previous study in Smithers, there was a significant improvement in RHI and CRP. So I would have to say, I would personally say we would need more studies to convince politicians. I mean, with thousands of them, they wouldn't get convinced. And so one or two, I don't think, would be that helpful.
Thanks. This is a little more technical question. I don't know if you'll know or not. I know you were looking at differences in CRP, but I don't remember my reference ranges. But for cardiovascular health, very, very small increases in CRP can be indicative of, you know, risk for cardiovascular disease and atherosclerosis. So I was just wondering, is this like a high sensitivity CRP
yes,
method?
Yes, it's high sensitivity.
Yeah, okay, that's what I was wondering.
I'm going to follow up on the Woodsmoke stuff. So you used Tim Larson's Woodsmoke model, and you use the areas in that model that were sort of the highest. Know how high the Woodsmoke was in those areas relative to something that we might see in Smithers or Cornell or any of the really highly impacted communities in British Columbia?
I think, if I remember correctly, I don't remember the exact number, but from the top of my head, I think somewhere between 15 and 20 micrograms per meter cube, or maybe less. I don't remember off the top of my head right now.
So you can, you know, with Ryan's study at one end and your study at the other end, and you start filling out the information in between from more and less impacted communities, whether or not you could start seeing that kind of dose-response relationship in the outcomes. But
I think the more important one thing I would say is that I think our sampling showed really lower levels than that. I think for Woodsmoke, we're looking at 7 micrograms per meter cube outdoors. So it was definitely lower than what Ryan Allen saw in Smithers, which was around 11 or 12 micrograms per meter cube.
And was it a smoky seat? Like, was it? I saw the temperatures were lower than in your non-wood smoke community, but was it a cold season when you were sampling? Like, did you notice a lot of wood smoke around when you were sampling?
It was a cold season. I mean, I think we did most of the sampling. Bob would know better because late December, and then it was mostly cold seasons, right? Because of that's. Okay.
Okay, just for the online audience who missed that, Bob Carlin was saying that there was, the sampling started up in September and there was some, December, I couldn't even hear, and there was some overlap between the traffic homes and the wood smoke homes. Okay, well, if there's no further questions, we can all get out into that beautiful sunny day. Thank you so much, Majid.
Thanks a lot.